thank you very much for the invitation, to the organizers for invitation. And I'm Noorul, a pulmonologist or chest physician, you can call whatever you want, and from Hospital Serdang. So I was given a task to talk on the update on the interstitial lung disease, ILD clinical trials in Malaysia. So, okay, don't worry, I'm not going to talk on the scientific clinical papers, trial or journals, you see. So it just highlight what are the current practice of or management of treating interstitial lung disease and what we have in our pipeline or a new frontiers treatment. So I would like to thank the speakers earlier than me, Dr. Felix, Dr. Shakirin, and Dr. Shirin, for making my talk much easier, make my life easier, because most of what I am going to speak is already been well elaborated by these speakers. Okay, so these are the agenda of the talk. So I will speak on the current treatment landscape in terms of the interstitial lung disease, which is the idiopathic pulmonary fibrosis, IPF, and non-IPF progressing fibrosing interstitial lung disease, which was being elaborated by Dr. Felix, Dr. Shakirin, and Dr. Shirin again. And also we're going to see what are the clinical trials available in our country. So before I proceed, basically this is the comprehensive care of ILD patients. So as we know that the diagnosis is made, or we all discuss the patients through the multidisciplinary team meeting attended well by all the teams involved, like the chest physician, the rheumatologist, with or without the pathologist. And also the most important things is the thoracic radiologist. And again, once the diagnosis is made, as you can see, we know that the process of getting to a diagnosis can be long and challenging. So once we diagnose the patients, the educations of the disease, how the disease evolve, how the disease can progress, their prognosis, and the self-management is really important. We should counsel our patients so that they know what's going on with them. So we might have a different perception, and patients have their own perceptions. So in whatever we want to treat our patients, we have to convey our plan, what we are doing, so that they have an idea what's going on with them. And the pulmonary rehabilitations is crucial so that they can maintain their quality of life and also have the best of what they can, and always make sure that we assess and prescribe the oxygen therapy when needed. So disease-targeted therapy in terms of the antifibrotic, immunomodulatory, and others that I will be show you in the next slide. And the role of hospice and palliative care, we should address earlier in the disease management. Not only we incorporate this part or of the service at the end of their disease. Maybe the disease already advanced, and only we start, referring these patients to the palliative care. So it should be integrated in our service earlier on. And the lungs transplant consideration for each patient, ILD patients, then, and we try to make an early referral to the lung transplant center. And this is the disease-targeted therapy. It's not only pharmacologic therapy, which is the antifibrotic and immunomodulatory therapy. And yes, the clinical trial options. We have heard a lot about the limitations of the funding, of the costs. So this is the importance of having clinical trials in our country so that the patients can have at least the options to the treatment, okay? And also comorbidities, which is associated with interstitial lung disease, which is already highlighted by the previous speakers. In order to control the disease, we also have to highlight their comorbidities and the symptoms management, like cough, breathing difficulty, dyspnea, and also in preventions in terms of a vaccine, etc. So what are the current treatment of IPF? So basically, this is the key phase 3 clinical trial from 2010 to 2014. And this is the landmark trial, I would say, in IPF that make a lot of difference in managing our patients. Like what Dr. Felix say, perhaps we don't have this antifibrotic 10 years ago. We have nothing. Basically, it is like the cartoon slide. You come, you see the patients, and then, okay, I am so sorry, nothing much we can do. All right? So, but now we have this a trial, like Panther trial is basically, we know that previously for IPF, many chest physicians use a combination of drugs, prednisolone, which is cheapest drugs, like Dr. Shakirin said, and azathioprine and N-acetylcysteine. But this combination, they use without knowing the efficacy. There were no study. So once Panther was designed, so it was proven that this combination bring more harm to the patients, increased risk of morbidity and mortality. So the study was terminated earlier, and there was basically a recommendation against the use of this combination therapy. And what about the ASCEND? ASCEND is a study looking at the efficacy of pirfenidone. Pirfenidone, which is one of the antifibrotic, but it was not in our formulary. Okay, so, and IMPULSIS 1 and 2 is looking at the efficacy of nintedanib, which is in our formulary in Malaysia. So basically, this is a guideline that based on this clinical trial. So a conditional recommendation for use nintedanib and pirfenidone based on the ASCEND and IMPULSIS clinical trial. So this is to highlight the importance of having clinical trial, of doing clinical trial, and the importance of contribution from our patients in joining the clinical trial. Okay, so what about the non-IPF fibrosing ILD? When we said non-IPF fibrosing ILD, so it's other than the idiopathic pulmonary fibrosis. It could be from the HP, hypersensitivity pneumonitis, that been, I think, nicely shown by Dr. Felix in the slide, consists of, I think, 5 years of CT scan, showed the disease progress, and also nicely elaborated by Dr. Shirin. Okay, it could be due to connective tissue disease, commonly is systemic sclerosis, associated interstitial lung disease. So now we looking, okay, but there are few things when we talk about the non-IPF fibrosing ILD. So it encompasses a heterogeneous groups of condition, mainly this from the connective tissue disease origin, the majority was the systemic sclerosis associated ILD, rheumatoid arthritis associated ILD, idiopathic NSIP, and unclassifiable ILD. And it is still important for us, although this disease progress, you can say that, oh, this is a fibrotic ILD, but this is still important for us to diagnose what are the underlying ILD this patient have. For example, for hypersensitivity pneumonitis, because we should counsel the patients basically to avoid the inciting antigen. And also been highlighted by Dr. Shirin's slide, the comorbidities or extrapulmonary involvement in the CTD ILD. So it is a multi-system, multi-compartment involvement in connective tissue disease. And there are limited data for the non-IPF fibrosing ILD, but we do have a data from systemic sclerosis ILD study and also progressive form of ILD, which I will highlight later. And also there is a guideline published recently regarding progressive pulmonary fibrosis that was just basically highlighted by Dr. Felix in his talk. So as a current practice, okay, nintedanib was approved by the FDA for systemic sclerosis ILD in September 2019 and the European Medicine Agency in April 2020. So basically, and also the tocilizumab was approved by the FDA for systemic sclerosis ILD in March 2021. But as a first-line therapy, is still often mycophenolate mofetil, as basically based on the study of SLS study, scleroderma lung study 2, which due to the safety profile of NMF as compared to the cyclophosphamide drugs. But at least we have more options besides than the cyclophosphamide that we have, nintedanib, and also the tocilizumab, because we know that the cost again is very important when we want to decide which treatment we want to initiate to our patients, especially here. But from Dr. Felix's presentation just now also, it's not just our problem in our country regarding this issue of funding. It's happened also in UK. All right. So for the progressive fibrosing ILD, just now we see the study in the systemic sclerosis, but this is the progressive fibrosing ILD. So Dr. Felix also highlighted nicely on the nintedanib in inbuilt trial and with all the data. So what I want to say here is it just that, this nintedanib will lower the annual rate of FVC decline compared to placebo. So I'm not going to elaborate further, as Dr. Felix already discussed about this. So the challenges, all right? So these are basically the flow of our current standard care. So when we diagnose, and then we start immunosuppressions, and then we observe again whether these patients respond to the treatment or not. And we see if the patients progress, or whether you can assess through the lung function or the symptoms or the CT scan, HRCT findings, and then only you want to decide, oh, this is the disease progress, and you want to give the antifibrotics. So the time. So again, the time is very crucial because Dr. Shakirin already mentioned about the delay in terms of referral, delay in terms of diagnosis, delay in terms of the investigation and delay in terms of initiation of the treatment is because for the many reasons. So again, when we have the treatment, but we don't have the funding, the cost is the issue. So this is the challenges in treating ILD patients. And it's not just in Malaysia, but also I think this is a worldwide problem. So now we have a good news here. Okay, the last slide was the good news slide. Okay, so that's what I learned. So now we have the clinical trials in Malaysia. So we have to, so whenever, how do I say about this? But these clinical trials, yes, again, it is only available basically in the tertiary referral center. And again, there is limitation also in terms of the referral, delay in referral. So we have to create the awareness of basically and overcome these challenges. So we have to educate our healthcare workers. I think not in the not in the tertiary center now. So the aim is to create the awareness at the primary healthcare, at the klinik kesihatan or the minor hospital with perhaps a medical officer or specialist, general physician. There is no resident rheumatologist, there is no resident chest physician in-house, so that they can have this awareness, can detect the disease early, and can make an early referral to the tertiary center with the respiratory services or the ILD services. And we have to make this clinical trial basically known by the other centers. So we have 2 phase 2 clinical trials and 1 phase 3 clinical trials. So thank you, Dr. Shakirin, for providing me with this slide. So as we know, this is a phase 2 multi-center study evaluating the safety and efficacy of taladegib in suspects or subjects with idiopathic pulmonary fibrosis. This is the first ILD clinical trial available in Malaysia, and 5 centers were selected to participate in this study. IPR, Institute Perubatan Respiratory, and Hospital Raja Perempuan Zainab in Kota Baru, Kelantan, University Malaya Medical Center, UKM Medical Center, and Hospital UITM in Puncak Alam. Yeah. So this is the second clinical trial available. Oh, sorry. This clinical trial is already started. They are actively recruiting the patients now. And I hope that more patients will be basically referred, okay, to this all the center involved, so that it can be assessed and can be recruited for this clinical trial. And the second clinical trial for IPF is a phase 2 randomized double-blind, 4 arms active and placebo-controlled dose in patients with IPF. We have 4 centers been selected for this clinical trial, which is IPR, Hospital Serdang, HTAA in Kuantan, and University Malaya Medical Center. So this study has not been started yet. So we're going to have I think perhaps by early next year. So the third clinical trials are The phase 3, the only phase 3 clinical trials, it is a randomized double-blind placebo-controlled trials, and 4 clinical study centers been selected: IPR, Hospital Serdang, Hospital Pulau Pinang, and Hospital Umum Sarawak. So these are the 3 clinical trials. But for the third one, they have, interestingly, and I think this is a very good news for our patients, because because this is a 2 parallel study. Basically, we are recruiting the idiopathic pulmonary fibrosis and also non-idiopathic pulmonary fibrosis interstitial lung disease. So the hypersensitivity pneumonitis patient we can recruit, the connective tissue disease patients also we can recruit. So all these patients who are fulfill the progressive phenotype, the disease progress, despite on the current or standard care, then we can assess the patients to see their eligibility for the clinical trials. Okay, with that, I think this is the last slide. Thank you very much.